Hi, everyone. My name is Sarah Michaels, and I am the Vice President of Kinetic Health here at Apex Benefits and a registered nurse by background, still currently practicing at Riley Hospital for Children. As a clinician, I am thrilled to be the one that gets to lead this month's webinar on such a hot topic, weight loss drugs. Now, before we get started, I want to start by saying a few things. The purpose of this specific webinar is truly around education. It is not my intent at all to take a stance for or against these medications. While clinically we know that there are effective weight loss agents on the market today, financially we also know that they are not yet a feasible solution for all of our viewers. I want to also acknowledge that we as humans are so much more than just our weight. And while obesity is the topic of today, there are so many personal factors that go into our health journey and our overall well-being. So please know that you are not alone in exploring the options that you feel are best suited for you. And lastly, this is just a starting point. Today's conversation is really starting to educate you guys on what's out there in the marketplace. But these are all discussions that I really encourage you guys to continue having with your primary care physicians, especially if this is an option that you want to explore as a possible solution for your healthcare journey. So we have a ton to get through today, and I will jump right into the agenda. Now, if you are somebody who is part of the benefit strategy decision at your workforce, maybe you are a sweet executive, I want to encourage you to reach out to somebody on your account team or myself following this webinar, because today's webinar was taken based off of the past 3 months. We have been doing an employer-facing series all about the impact of weight loss drugs. Today, I am taking all of those 3 series. I am bringing it down to 30 minutes to really give our employees the highlights and the most important facts when it comes to your own personal journey. So we're going to start today by a brief history on obesity, the epidemic we're in today, and just the clinical impact it does have on us. We're also going to talk about the history of weight loss. So believe it or not, treatment has been around since the early 1900s. So why are we just hearing about it in recent months or in recent years? A lot of it comes down to social media. So we'll talk about the impact social media and the news has had on these weight loss drugs today. And I want to spend the bulk amount of our time specifically educating you guys on what in the world are GLP-1s and GLP-1 GIPs, fancy little code words that I hear about a lot. This is something that I've walked alongside with my patients for years now, and so I'm excited to bring this knowledge to you guys. And last but not least, really want to talk about best practices for sustainable weight management. So what you're going to hear today is a lot of solutions that work while you're on a treatment, but what is actually sustainable for long-term weight loss? Now, throughout this presentation, if you guys have questions, feel free to put it in our chat box. We might not get to the live questions today, but rest assured, I will work with our team of pharmacists to make sure that we respond to each and every one of your questions by the end of this week. So it's important to start by really defining what is obesity. And in simple terms, a lot of people just think of this as a weight that is considered unhealthy in relationship to our height. So as clinicians, it's very similar. Go back to your high school days. You probably remember BMI, body mass index. And there's really only 2 components that go into our BMI, and that is our height and our weight. Now, I personally love the graph on your screen. If you don't love math, there's also math on the bottom there. But you can quickly look at your weight and look at your height, and you're going to find a color on where you fall and what is considered your body mass index. Now, technically, a BMI greater than 30 is considered to be obese, but really that 25 to 29 is where we start to talk about overweight. For the purpose of today, and when we talk about GLP-1 specifically, the clinical indication starts for weight loss specifically, starts with a BMI greater than 30 or a BMI greater than 27 if you have another chronic condition, such as diabetes, high blood pressure, high cholesterol. Now, why we don't necessarily love BMI as being that telltale truth for our obesity measurement is because if you think about it, 1 pound of fat looks very different and feels very different on our body than 1 pound of muscle. That is why two people could weigh the exact same amount, could have the exact same height, and our body composition is so different. As clinicians, that's why if you talk to our dietitians on the team, we don't necessarily love BMI, and unfortunately, that is what we use when we talk about these weight loss drugs. But keep that in the back of your mind, because just because your BMI might have fallen in one of those obese categories does not really mean anything. That's why we say talk to your doctor, because all of our bodies look and feel differently. And somebody that might have a high BMI might actually be really in shape. They might be a bodybuilder. So I wanted to highlight that here. Now, believe it or not, obesity did not even get categorized as a disease state until 2013. And the reason it even became categorized as a disease state was the healthcare world found that doctors still had a lot of stigma surrounding obesity. A lot of providers treated it like it was a very personal decision. If you eat too much, if we don't exercise enough, we're going to be considered obese. But the reality is, and research has shown over the course of several years, that's not the case for all of us. And so it was very important that we categorize this by the American Medical Association as a disease state. And then more importantly, we tried to change the stigma around obesity so we could actually start to do something productive and see changes in the way that we treat obesity. When we talk about prevalence and we talk about future trends, when I say you are not alone, I truly mean that. This is looking at as recent as 2020, so right before the pandemic. In the state of Indiana, 37.7% of adults were categorized as being obese. This is just obesity. This is not looking at those that were categorized as being overweight. What does this mean worldwide? Well, worldwide in 2020, it was about 38% of the population had obesity. If you look at the next 10-year trajectory, we're projecting that 1 in every 2 adults will actually have a formal diagnosis of obesity. It is the number one chronic condition that we face in the healthcare world today. And it's time that we really start treating it as a chronic condition. This is not an acute condition. This is not something we can put a Band-Aid on and fix overnight. It's truly chronic, meaning once we have it, it will remain part of us through the entirety of our life. Now, there are known medical causes for obesity. I'm going to throw the obvious one out there. If you're pregnant, we know that we are going to gain weight. That is why, personally, I'm not the biggest fan of some of the weight loss challenges that we used to see in the workforce, because there are other conditions such as an illness. If you think about any sort of acute illness that you absorb body fluids, that's going to increase our weight. There's microbiome reasons. So there are actual genetics that play into obesity. And then certain medications. How many people didn't want to go on certain birth control medications specifically because a side effect known is obesity? So multiple medications, a lot of which are common medications, do have a side effect of obesity. So no, it is not always a personal decision to be battling this. And what I love to educate folks on is the social determinants of health and how much they play into obesity. Think about it, and you can kind of read the screen. If I live in a neighborhood that's a food desert and I don't have access to a grocery store or a farmer's market, and I can't just easily go pick up fruits and vegetables, or maybe I can't afford that because unfortunately those are usually the most expensive food groups, but McDonald's is down the street and they have $2 that I can quickly get something to eat. There's a lot of social determinants of health that go into this. So when I was doing the employer facing webinar, I really focused on how can we bring healthy habits into the workplace, even if it's as simple as changing what we provide in the break room to eat. So some healthy snack options, maybe some flavored waters. Can we stand up and stretch? I know at Apex, we've been having a really fun month of May, Move More May, where we get out and we just go for walks as a team. So think about ways that you can increase some of these opportunities even within your workplace. And what are the effects on obesity if this goes untreated? Lots, right? Think about it. If I have extra fat that is sitting on my bones and my joints and different parts of my body, I'm going to start to see multiple different conditions arise. One that people don't think about is what happens when that fat's sitting on those joints. In particular, think about like your kneecaps. It really starts to break down. And so we're starting to see a higher number of surgical procedures related to obesity, such as hip replacements, knee replacements, high cost medications for arthritis due to some of that pain. And then the more common ones are cardiac related, which we'll talk about here in a little bit. I always like to look at it in nursing school. If you think about your blood vessels as really like that hose, if you start to put more inside of that, so your fat is building up, it's getting a lot thinner for where you can force things through, where that blood goes through. That's what essentially is leading to heart attacks or needing a cardiac procedure, right? We need to open back up those blood vessels by removing some of that built up fat. And then treatments. I already teased it early on. They have been around a lot longer than we think. And in fact, back in the 1930s, when researchers started to evaluate options for weight loss drugs, that was when the class of stimulant drugs came out. And believe it or not, methamphetamines used to be one of the treatments of choice. We now know there's that addictive factor. And so we absolutely wouldn't recommend it. But at the time, researchers really thought that obesity was the direct result of overeating. And what methamphetamine actually did was short term, it would reduce our appetite and it sped up our metabolism to some crazy high rates that actually started to burn fat quickly. So that was when we first started to see treatment. And if you think about where we're at, even before GLP-1s today, we have introduced certain oral medications, and I'll speak to those in a bit. We also know that the treatment for obesity is oftentimes weight loss. So back to our building blocks of health. How can I eat healthier? How can I exercise more? How can I even get enough sleep? Because believe it or not, sleep helps us maintain certain hormones in our body, which absolutely help us maintain our weight. So lots of treatment options. And then there was a very invasive treatment option, which was bariatric surgery, which was cutting edge back in the day of this is the treatment of choice. But Mayo Clinic actually looked at a long-term research study of those who went through bariatric surgery, and they found that only 40% of all of those individuals actually maintained weight after 12 years of their first encounter with that. That means 60% of people who had this extremely invasive surgical procedure actually rebounded and had a weight greater than what they were pre-surgery levels. This study really shows us that there's not a one size fits all. There's not a quick fix to this. Like I said, it's a chronic condition. So although I can do something to fix it immediately, I need to talk about what long-term sustainable options exist if I want to achieve overall improvements to my health and, of course, sustained weight. Okay, so this is why you're joining me, and I want to get right into it. What are GLP-1s and what are GIPs, which is the newer class of GLP-1s? So GLP-1s, or glucagon-like peptide 1 drugs, they are a class of medications that were originally indicated to treat type 2 diabetes and now have also been indicated to treat obesity. They actually work by mimicking the natural GLP-1 hormone, which is this hormone that our body actually releases anytime we eat food. So it's enhancing the amount of GLP-1 hormone I have in my body. And what that enhancement does is 3 things. The first is it signals to our pancreas that we need to release more insulin, which at that point is going to decrease the blood sugar levels in our body, which is why this treatment has been so effective for diabetic populations. The second thing it does, and perhaps the most important part when we talk about the weight loss indication, is it actually acts on our stomach to slow the rate at which food moves through it. And by slowing the rate at which food moves through our stomach, what we are doing is we're feeling full longer because it's sitting on our stomach. And the third part that really ties into that is it actually works on our brain and it tricks our hypothalamus into thinking that, okay, it's sitting on my stomach, I'm full now. So our brain thinks we're fuller faster. And therefore, the goal of these drugs is it actually helps us eat less food in each serving. Okay. Now, GLP-1, GIP, It does the same thing I talked about, but we add that GIP. And GIP is gastric inhibitory polypeptide. It is also a hormone that's released when we eat. And the only thing you really need to know about this is that that directly actually also impacts my metabolism. So now I've got my stomach slowing down, I've got my brain thinking I'm full, and now my metabolism is moving faster. And these drugs are now the most effective when it comes to our weight loss drug solutions. There's only one currently in this category today, and that's Zepbound. So we'll talk about Zepbound here in a bit. If you're from Indiana, you probably saw it in the news as recently as Friday when Lilly released this massive press that they are spending over $9 billion to build a brand new facility here in our state specifically to tackle some of these drugs. Okay, so weight loss medication. I told you we'd talk a little bit about the history. Reality is weight loss drugs have been around a long time. I joke that we've only heard about them recently because a lot of people who have been able to afford the medications are some of, they always say, your LA celebrities, right? They're on TikTok. They're talking about this miracle cure. Everybody is trying to figure out more about these. But before the weight loss drug injections came around, we actually had these weight loss oral medications. So you'll see that on the left side of my screen. Today, there are 3 oral medications that are still available. Okay, let's talk about GLP-1s. These are our injectable weight loss medications. I love this slide because I think this slide really will educate you guys on like what is the difference. A lot of people have heard about Ozempic, Mounjaro, even Victoza. Those were the initial drugs indicated for diabetes. So if you hear those drugs or you see those drugs on your plan, that means somebody's taking the medication that has a clinical indication for diabetes. So they have that diabetes diagnosis. Now, right below those drugs are their counterparts, Saxenda, Wegovy, and Zepbound. Those are the 3 drugs that have an indication for obesity. And when you ask our pharmacist, okay, like what is the difference? That's the difference, their actual indication. And that changes how the pharmacy industry will actually market these medications. So if you hear about Wegovy or Zepbound on the news, that is specifically targeting people with obesity. So that's a fun fact that I was always trying to keep it straight and could never figure out the difference. This chart does it for you. You're going to see that Saxenda is actually a daily injection. So every single day, essentially for the rest of your life, you'd be giving yourself this injection. Now, Wegovy and Zepbound currently are weekly injections. So 1 injection once a week is how you take these medications. Side effects. I get asked all the time as a nurse, what are the side effects? Nausea, diarrhea, vomiting, constipation. These are the biggest ones you see. And you see this because, again, if you think about what's happening in our body is essentially slowing down our stomach. It's telling me I'm not full anymore. But if I continue to eat the same amount of food that I was eating pre-drug level, my body's really confused now because all of a sudden, where does the food have to go? And that's why we see a lot of these adverse drug effects. We also see more drug reactions in somebody that maybe has a lower BMI and wants to get on these medications and doesn't have as much fat to necessarily be burning. And so it's more common to see that. We're also hearing about side effects a lot more, honestly, because more people are getting on these medications, right? The more amount of people I have, the more talk there's going to be. And we have to say, especially as healthcare workers, there are some rare but serious side effects, 2 that aren't on here that I actually want to highlight that we're starting to hear more about. The first being stomach paralysis or gastroparesis, which is over long term, which again, these drugs haven't been around enough to really know 10 years from now, what are these adverse effects going to be? But we have seen a couple instances of gastroparesis, which means your stomach essentially just stops working the way it should because the drug is tricking us to think that we can't move the food through our stomach. And then muscle wasting is another more common adverse effect. And what that essentially means is if you're not working out alongside of taking these medications, what can actually happen is once there's no more fat to be burned, it actually starts eating into your muscle. And that's why you also have heard on the news that you can start to see that face, a thinner face, because a negative impact can be it starts wearing on your muscles. So it's very important that this is not a standalone solution to weight loss management. You really need to still be making sure I'm eating healthy portions of food, I'm exercising regularly, and especially adding some strength conditioning into my workout. And of course, I'm following all of the doctor recommendations in terms of dosages. So if you're getting some of these side effects, chances are the drugs could be a little bit too high of a dose. And so you should be frequently checking in with your providers if that is ever the case. Now, let's talk about the efficacy and what can we see from a weight loss perspective. Now, in order to improve any health outcome, our body loss goal should always be about 8 to 10%. We know with 8 to 10% of a weight loss reduction, we're going to start seeing improvements in our health. Think about that, because the top 3 that you're seeing here on the screen are actually oral medications, so much less invasive medications that also come with a cheaper price tag that we'll see here in a moment. The bottom 3 are those injections that I've been talking about, or the GLP-1 drugs. So the one I want to highlight is Qsymia. Qsymia has almost a 10% average weight loss, which is basically really close to those GLP-1s. And in fact, 48% of people who have taken that oral medication specifically have seen greater than 10% weight loss. So that is a really good option for people that if you're like, hey, I don't want to jump ship immediately into these injections, I want to try a less invasive method that maybe I can afford. That's a really good option that I'd encourage you to really talk to your doctor about. Let's talk about the cost of these drugs. This is also what you hear a lot about. This is probably the biggest reason people are not on these medications. We know today that a lot of insurance companies are not covering the cost of these drugs. They will cover it for those that are diabetic indications, but not yet there on the weight loss management. And I'm going to talk about why. WAC, which is wholesale acquisition cost, is essentially a pricing benchmark that the drug industry uses, and it gives us an estimate of what the medication price will be. So look at those prices for the top 3 and compare those prices for the bottom 3. You see the Qsymia that I talked about is about $2,500 annually. And when you talk about Zepbound or Wegovy, we're talking over $10,000. We're talking about $1,000 a month to be on this injection. So you really have to weigh pros and cons in terms of, what can I afford? And most importantly, what can I afford long term, knowing that I have to stay on this drug likely the rest of my life to manage a chronic condition if I want to see that sustainable weight loss, that the results that you showed. 75% of employer groups have chosen not to cover GLP-1s for weight loss. And this is pretty controversial because there's a lot of people who say, this angers me and they don't care about me. And I want to be the one to say it's quite the opposite. I'm part of these conversations with HR leaders who genuinely care about their people, want what's best for them, are always looking for what can I do to improve their health and care about them as people. But the reality is, quick math. If you have 100 members on a medical plan, and that might only be 50 employees at a workplace, that would cost a group about $500,000 to cover those individuals if they were to put weight loss drugs into a plan. $500,000 is enough for some of these smaller companies to literally go out of business. So this truly comes down to a business decision on whether or not we truly can even cover the cost of these medications, which is why we're starting to see a lot of employer groups pull out. Now, the good news is hopefully with the creation of more and more drugs coming to market, we're hoping to eventually see the cost of these drugs going downwards. And if so, and if they keep the clinical indication and they're shown to work, hoping long term these drugs might become more accessible to all of us. So why pay for these drugs? What are the biggest arguments I hear from employees that want these to be covered? Understandably, the cardiovascular impact. If I think about it, if I can improve my health, if I can lose 20% on average of my body weight, what I'm hoping to do is improve my cardiac health. But there's just not a lot of studies out there today. The ones that we have here were studies done in the diabetic population, and our bodies in a diabetic are much different than our bodies without diabetes. So there's a lot of pending outcomes we're still waiting on. But the one that we do have was done by Select Trial, and it was done specifically on Wegovy. And you're going to see they had a large number of individuals participate in the study. It was over 17,000 people. But what they found was it actually took 3 years of treating 67 individuals to prevent one cardiovascular event from happening, which is likely at that case a non-fatal heart attack. 67 people, 3 years to prevent just one of those events from happening. That would have cost a plan $2 million. And I'm not to say that a person's life is not more important than money, right? But this just, it really reframes your mind when you see these numbers and you understand these are really expensive. And unfortunately, some of those long-term events just aren't always preventable. And a lot of it comes down to, okay, so if I'm losing weight, why am I not seeing greater cardiovascular risk? Why am I not seeing that decrease? There's a lot of wasteful spend. So some are simply due to side effects that people are like, I'm done. I don't want anything to do with this anymore. Unfortunately, a lot of it comes down to people that want it as a short-term fix. So maybe I have a wedding coming up or it's bikini season. And so I want to take these and I want to lose the weight and then I want to be done. So a PBM, which is a pharmacy benefit consultant, did a study back in 2021 and found that only 27% of utilizers stayed on these drugs after 1 year of therapy, which means for a year they lost about 20% of their body weight. But then what happens when 73% of those members go off? Well, we know now, based off research, that there is a weight regain. It's not a question of if, there is a weight regain because it's a chronic condition and it is not a miracle cure. A cure would fix the disease. This is not a cure. It's simply helping us sustain it in real time. On the left side of your screen, you're going to see when those individuals started their treatment, you see that graph go all the way down and you see how much body weight they were lost. And then you're going to see those dotted lines that show you when somebody stopped taking the medication. And you see that literally instant rebound of weight. Because what's happening is I no longer have this medication telling my brain that I'm full. I no longer have my stomach slowing down how food moves through my body to feel full. And so portion sizes go back up. And that weight just starts piling back on. On the right side of your screen, you're going to see the trial, the actual Zepbound results. So those individuals who stayed on the drug past 36 weeks saw an additional 5.5% of weight loss. But those individuals who stopped taking the medication saw a 14% average weight gain. So with that being said, what is sustainable? And I know we only have about a minute left to talk about this, but the good news is there are less costly solutions that I always encourage people to start with. Before you even start taking this kind of miracle injection, you really need to ask yourself, like, financially, long-term, can I sustain this? And what do I have in place to actually help, should I no longer be able to afford this? So how do I start these habits now? How do I start exercising? So basics for exercise as adults, we really need at least 5 days a week to be having about 30 minutes of that moderate activity. 2 days, I would really encourage you to add some strengthening activities, especially knowing that these injections can start doing that muscle wasting. For older adults, it's the same thing, but we also want to talk about balance. And so little exercises you can do to do balance are as easy as standing on your foot. And then when it comes to our diet, we know nutrition is key for weight loss and sustainability. So always read your food labels, talk about portion sizes. A lot of you guys have heard the plate method, but I'll quickly go through that. It means that in terms of your plate, we want to fill half of our plate with a non-starchy vegetable. And that means that we're lowering our carbs so that it really regulates our blood sugar level. Think about asparagus, broccoli, carrots, peppers, salad greens. They all fall into that category. On a quarter of our plate, we want lean protein foods, so fish, chicken, lean beef. If you're looking for something that's not meat, beans, lentils, hummus all provide great protein. And the last part of our plate, that last quarter, should be focused on having carbs because carbs do help us with our sugar levels. So healthy carbs would be whole grains, add some starchy vegetables like a squash, like potatoes, fruit, yogurt, all would be great on your plate. And then you want to finish it off with that low calorie drink. So water, unsweetened tea. I mentioned adding some flavors to your water, anything that can really keep your calorie count down. And it's really important to know we never want to skip meals. Even if we're on these medications, don't skip meals. Don't cut out certain food groups. Our body needs all of it. They're all important nutrients. They all help us regulate our blood sugar, which is so important with sustaining our weight. And for some of us, it might be as simple as really tracking our food. And so, if weight management, if exercise is something that you really need some help with, or you would like extra resources, please reach out to our team. We have a whole staff filled with nurses, dietitians, social workers, everything in between, pharmacists, of course, that we would be happy to provide health coaching and really help point you in that health journey. I know we're right on time, so I won't answer questions live, but please know that I see the questions on the screen. We'll go through these and I'll work to get you guys answers as soon as I can. And I also want to highlight, if you're an HR leader or someone who is focused on benefits at your organization, please reach out and ask us specifically for a free copy of the 2024 Employer Impact Report. Our marketing team did an incredible job putting together basically a great playbook about do's and don'ts of covering these medications and all things to think about. So we would love to send you guys copies because they're hot off the press as of a couple weeks ago. And if you have any specific questions for me that I can help you with, I want to provide my information. I am an email away. I would love to carry on this conversation. I know in the interest of time, that was a lot to fit into 30 minutes. But as I said, I hope more than anything, we can educate you on what are these drugs, what are their side effects, what does this look like from a cost and a weight loss perspective, to give you guys that starting point to have these conversations with your healthcare providers. So thank you guys so much for joining us for this webinar. I hope it was beneficial, and we look forward to seeing you guys on the next one. Have a great day.